Our next speaker this morning has flown from Arizona to Washington, D.C., to Topeka, just to be here with you this morning. Dr. Balfour is a psychiatrist and national leader in crisis care, quality improvement, and law enforcement responses to behavioral health emergencies. She's the Chief Quality and Clinical Innovation and Connections Health Solutions, Associate Professor of Psychiatry at the University of Arizona. Dr. Balfour was named Doctor of the Year by the National Council for Behavioral Health for her leadership in crisis response in Tucson, Arizona, and CIT Practitioner of the Year for her work to help law enforcement better serve people with mental health and substance use needs. Educated at Johns Hopkins University, Dr. Balfour is now a Distinguished Fellow of American Psychiatric Association, serves on the APA Council for the Quality of Care, boards for the American Association for Community Psychiatry and American Association for Emergency Psychiatry, and numerous expert panels for SAMHSA, the DOJ, and many other organizations. Yesterday, we had a theme and we had a question about asking ourselves, are there better solutions? Dr. Balfour is here this morning to present one of those options where the answer may be yes. Please welcome to the stage, Dr. Balfour.
Where's the clicker? Ah, thanks.
Anything else? You good?
I'm good.
All right.
Thanks. Well, thanks for having me. And that was a great and very inspiring way to start the morning. And I'm hopefully can help inspire y'all that it seems like fixing the system is nigh impossible, but there are places that are doing some good work, not just Arizona, but around the country. And so I'm going to talk to you about what we're doing out in Arizona, but also about some work that I've been part of to help create a blueprint or a roadmap to help other communities as well. And I'd like to start out with this quote. I guess being in Topeka, kind of didn't realize it till I got here, but it's pretty timely because this is a former Representative Patrick Kennedy, and he's been talking about this disparity between and this lack of parity that we have with mental health and substance use care compared to the rest of healthcare, and framing it as a civil rights issue, and notes that we have two separate but unequal lines of treatment here in this country. And I guess that would be familiar to you with the Board of Education Museum down the street, which Judge Leifman told me to go to when I was gonna, but then I found out the Evel Knievel Museum was also in Topeka. And I'm like, well, we all have our own heroes. So that is where I went, and I did the virtual reality jump, and it was really cool. But I will make it to that other, the more serious one also. But this disparity, though, nowhere is it more apparent in what happens with people with behavioral emergencies. I'm starting from the moment you ask for help. If I call 911 and I say that I've got chest pain, I get an ambulance with trained ambulance staff who that's their job, is to go out and do medical care and take you somewhere where you're going to get the medical care you need. And if you need to see an emergency room, and then if you need more care, that ER is equipped with a hospital bed that's going to be able to take care of you. But if I say that I'm suicidal, I get Chief Wiggin. And all of the CIT training in the world it's still that you're putting a armed law enforcement officer in a situation with a highly agitated individual who needs medical care. And so not surprisingly, the statistics on officer-involved shooting deaths, a quarter of those are attributed to some kind of mental illness. And then when you add race and ethnicity in there, the interaction is just multiplied, where if you've got mental illness, that puts you at higher risk of ending up with a fatal outcome. But if you're a person of color and with mental illness, it's magnified. And then in jails, like if you train all y'all officers up on how to like how to recognize mental illness and get people to where they need to be. If you don't have some place to bring them, then the path of least resistance is often jail, sometimes even well-meaning, of at least we'll get this person off the street. And there's this myth that they're going to get treatment in jail, where the data shows that, jails do the best they can, but that's not what jails were made for. And so most people do not get evidence-based treatment in jail. What they do get is incarcerated longer. They're more likely to be assaulted or put into solitary confinement, which makes them worse. They have their Medicaid turned off. They come out having lost, if they had a job at a home, they probably lost it. And then they've got criminal record, which makes it even harder for them to get a job. And then we go, oh, you should be doing better. And it's like, well, we kind of made it hard for them to do better. So that's why, how many of y'all are familiar with the sequential intercepts? Okay, good. So this is the pathway of the person through the justice system, where there are points for the mental health system to intercept them and make it, either get them out of the justice system altogether, or at least make it not so bad. And so 0 and 1 is where I'm going to be talking about, which is crisis services. So these are things, partnerships between the mental health system and law enforcement that are designed to prevent the person from being arrested in the first place. So to get them out of the justice system as early as possible, and by not even having them in there. So if you have all these great crisis services, another thing that gets in the way is that, so say you train officers up in CIT and you say, take them to treatment instead of taking them to jail. And they say, yes, I'll do that. And if the only option is the emergency room, well, we all know what happens in ERs, right? ERs are like the waiting game. So people with, most emergency rooms don't have any psychiatric capability whatsoever, which, again, speaking from like separate and unequal and parity, like it's not like an ER can say, well, we're just not going to do diabetes because we don't feel like it. Yet 64% of emergency rooms just say, well, we're not going to do any psych because we don't feel like it. And so oftentimes then, if the ER is not able to handle that, then the hospital becomes the path of least resistance, of where they're just going to put people on a list to wait to be shipped out to a psych hospital somewhere else. And that can be going on for days, sometimes weeks. And during that time, the person's not getting care. So not unsurprisingly, they get agitated. They are in their crisis. There are injuries of both the patients and the staff. The cost of this is astronomical. And then oftentimes they make the officer wait with them that whole time. And so it's no wonder that officers don't like taking people to the ER. I wouldn't either. And now we're talking about 988 coming. And, if we open up access through that, we can even make this problem worse if we don't have somewhere for those folks to go. So what we have is a system where a behavioral health emergency it's a potentially fatal health emergency. And yet we don't expect the same quality and consistency of emergency response as we do for other health emergencies. I mean, we wouldn't stand for this kind of system if your loved one had a heart attack or a stroke. Yet it seems okay, well, if maybe we can scrounge together enough funds, then we can have some kind of piece together mental health crisis system. And that's not parity. So, it was National Siblings Day the other day. If you've had a sibling, you know what parity is, right? You have exactly equal. And we do not have that. So 988, how many people have heard of 988? Okay. So this is supposed to go into effect in just a couple of months now, which is kind of creeping up on us. So this will be the new 3-digit number for a mental health emergency that's going to take place at the old Lifeline, which is the suicide hotline, which is the 1-800-273-TALK. But if you look at this, there's tons more behavioral health or mental health crisis calls out there that currently aren't captured by the Lifeline. The Lifeline are those green calls right now. There's about 3 million Lifeline calls a year. But there are other crisis lines that aren't part of the Lifeline, a lot of 211 lines. And in Arizona, our Arizona crisis lines, the Lifeline gets about 30,000 calls a year. The Arizona crisis lines get about 30,000 calls a month. So a lot more, actually. And then 911, people are just now starting to tap into figuring out how to divert 911 calls. And it's anywhere between 7 to 10% of 911 calls are probably behavioral health. And so if you do the numbers, there's a ton of mental health calls out there. But 988 is a good first step. And it's gonna, give people at least be in the mindset of calling something besides 911 for all emergencies. But I like to make memes, and sometimes I get kind of doomy and gloomy, because we've been talking about 988 for a while, and it's like, guys, like, what's going to happen after the call? Like, you think about having 911 without ambulances and emergency rooms. Like, we're kind of coming up on that with 988, and so we need to implement a crisis system to have the care that the callers need after the call, because frankly, many calls can be resolved on the phone, but for the ones that aren't, which are the ones which I see law enforcement uniforms in here, so the ones that y'all are dealing with every day on the street, there's a lot of those that need something more than the phone call, something after the phone call. So this is a report that lays out a lot of gives you a lot of guidance on how to start for your own communities. It's called the Roadmap to the Ideal Crisis System. I'm the co-chair of the committee that wrote it, and it was a joint project between the Group for the Advancement of Psychiatry and the National Council for Behavioral Health, which is now the National Council for Mental Wellbeing. But it really set out to say, because you've seen some of the guidelines that are out that talk about the core services like phones, mobile, and facilities, and our philosophy was that that's kind of the minimum, but that every community should be more aspirational and deserves a system that's just as robust and just as reliable and as good as what you would expect for emergency and trauma. So we start there and kind of go through how that, steps that communities can take and give examples and best practices. And a lot of it was based on what's going on in Arizona. And so why? You've probably heard a lot of talk about the Arizona crisis system, because when crisis comes up, oftentimes, people reference us. And so, why? I mean, why are we so special? Besides the fact that we are America's Australia, and we have lots of poisonous things that you have to check your shoes before you put them on. But a lot of the principles that are in that roadmap are part of the Arizona system. And so then by looking at these successes in Arizona, that inform the design a lot of the roadmap. And one core piece of that is thinking about systems. So this is a Saturn V rocket engine. And like a lot of people want to come and they want to see our facility, and they go, come, I want to tour your facility because we want a crisis system. And it's like, well, I could go and learn a lot about whatever that round thing is. I don't know what it is. It looks important, but just because I know what that round thing is and what it does, I cannot make a Saturn V rocket go. Same thing is every time you turn on the news, there's an article about some really cool program that's in some community somewhere in the country, and then people kind of go, oh, we need that. And yeah, you probably do need that, whatever it is, but the important thing is that it all works together as a system. And so this is an old slide from SAMHSA that just does a nice job of laying out tons of different types of services. They're along the continuum in crisis, meaning that they can take care of people at the beginning of their crisis, in the middle of their crisis, after their crisis, doing things to prevent another crisis. But the important thing isn't that you have one or two or three of these services, but it's that they are aligned and working together in a coordinated way towards common goals. And so that's why, one of the, when we wrote the roadmap, we actually didn't start with the list of services. We started down here at the bottom of the pyramid about the governance and the financing and the oversight, and having a framework to be able to coordinate a system to build your foundation. And then upon the foundation, you have your continuum of all the different services, and then the clinical best practices that are done in those services to support the community, to eventually, support the person in crisis. But you need that foundation to get that coordinated system where you have this synergy, where the sum is more, or the pieces, or the whole is more than the sum of its parts. And so three kind of key ingredients that we found that make a system work for crisis is, first, you have to have accountability. And just like we were hearing, from before, accountability is how you commit to something. And if we are going to say that we want a crisis system that is like aligned towards these goals and these values, how do we know if we're achieving that? Who's holding the different pieces of it accountable? Oftentimes that's linked to the governance and the financing, which is what I'll show in a little bit. You also need collaboration. So, I mean, everybody needs collaboration, right? But in crisis crosses so many different silos. So you've got the mental health system and the substance use system, which are separate in some states. And then the health system and emergency rooms and law enforcement and the courts and for civil commitment stuff, schools. Like, there's just so many different players there that you really need this culture of collaboration and problem solving, and where people have this mindset of, we're going to figure out how to say yes rather than look for reasons to say no. And then data. I'm nerdy, so I like data. But you need data. Like, if you're going to do, especially the first one, if you're going to be having accountability, how do you hold people accountable if you don't know how they're performing? Or, as a system, like, how do we know how well we're doing, and how do we know if there's areas where we need to improve? And so having data to guide your decisions is really important as well. So luckily for us in Arizona, a lot of that those concepts are kind of baked into the way we're structured. So Arizona is an interesting state too. I moved to Arizona from Texas, and when I moved there, I was like, this is awesome. It's like Shangri-La. There's Medicaid grows on trees out here. And the name of the Medicaid department was Access. And I'm like, it's all about access to care, and that's great. It stands for Arizona Healthcare Cost Containment System. So that's not exactly, the touchy-feely meaning that I thought it had, but it actually explains a lot, and it explains a lot about, like, why this red state that's like full of venomous animals like developed this wonderful crisis system. And a lot of it stems from that, because Arizona was the last state to ever have Medicaid, not Medicaid expansion, but just like any Medicaid. And it wasn't until the 80s, and it was in part due to a lawsuit around mental health. But the legend I heard, because it was before my time, was that the legislature wouldn't pass the law to buy into Medicaid unless it had the words cost containment in the name of the department. And so Access came about. And then the first thing they did was they turned around and got a statewide managed care waiver. So how many know what that is? Okay, just, yes, a very policy wonky thing. So what that means is, because Medicaid is administered by the states, but with a combination of money from the state and from the feds. And usually a state Medicaid department is just a department where, like, anybody like me, I could just put a shingle up and go see patients and send bills to it, and then somebody will pay my claim. Well, what a waiver does is the state goes to the feds and says, okay, give us all the money that you would have given us, and we're going to take that, and we're going to create a system ourselves, or we're going to contract out the management of it to, like, managed care companies and things like that. And but we have to prove to you that we are going to get the same outcomes or better, and we're going to spend the same amount or less. And so from the very beginning, someone had to be thinking of the system as an actual system, because that was kind of built into how this waiver works. Arizona was the first state to ever do that. And so we've never had fee-for-service Medicaid. It's always been this kind of systems view. And so the way that and then the other smart thing they did was they braided the funding together. So in a lot of states, you have a Medicaid department, and they do all the Medicaid stuff. There may be another department of behavioral health that has the other funds. So SAMHSA gives federal block grants to the state, the mental health block grant, substance use block grant, and that department may then give that money to counties or local mental health authorities or things like that. There may also be some state general funds for mental health and for crisis and for uncompensated, indigent care, that kind of stuff. And those departments are often all different. What they did in Arizona was they took all that money and they run it through Access to the Medicaid system to administer it. And so right now, the way it's working is the state is divided into 3 regions. So there's the North, Then there's Maricopa County in the middle, that's Phoenix. And then there's the south, which I'll be talking about the most. And then they put out for competitive bid an RFP to be the regional behavioral health authority for that region. And so ours for the south is Arizona Complete Health. They're part of Centene. In Phoenix, where we also have crisis centers, it's Mercy Care, which is part of Aetna, but they're managed care companies, but they have a lot more contractual stuff that they're required to do. And then they subcontract out to all of us provider organizations to do the services. So we're one of the agencies. There's agencies that are doing the mobile teams. There's another agency doing the phones and so forth. But we all work together towards these common goals. And one of the reasons why this works, in our venomous red state out there, is that regardless of where you're coming from, because I heard that it was like a big bipartisan love fest in here yesterday, which is really cool. This is one of those issues, because it gets people from both sides together, because you could, no matter like what angle you're coming from, it makes sense. Because what I want as a clinician is I want my patients to not be in jail, to not be languishing in emergency rooms and boarding for days and days, and to not be locked up in the hospital, against their will or whatever, if they don't need to be. And if you're paying for stuff, you also you want those things, because it's a whole lot less expensive to be doing well in the community and in community-based care than it is to be in jail and emergency rooms in the hospital. So whether you're coming at it from, this is like clinically what this is good care versus this is good stewardship of taxpayer funds, it's kind of win-win. So there's a lot of bipartisan support for this kind of thing. If you kind of look at it in a different way, so this is, we talked about how these services, like we want care in the least restrictive setting or least intrusive, where it's out in the community as much as possible. And then those services tend to also be the least costly services. So you can kind of line them up on a continuum. And the least intrusive, least restrictive, least expensive thing is to be able to pick up the phone and call somebody. So the crisis line for Southern Arizona gets about 10,000 calls a month. They are able to resolve 80% of those on the phone. They do that through telephonic counseling, but also because our Regional Behavioral Health Authority, or we say REBA for short, they have contracts with all the other providers too. So they can say stuff to the clinics and in their contracts and stuff and say, you need to put crisis appointments into the software that the crisis line has. So part of when they are trying to resolve someone's crisis in the middle of the night, they can say, oh, well, we have a appointment at clinic X down the street at 11:30 tomorrow. And that can really help relieve someone's crisis, at least knowing that they have somewhere to go. If they can't resolve the crisis, then the crisis line is able to dispatch the mobile teams. And so it's really cool. They have like this big map with all these blinky lights. It's like Uber, and they can see where all the mobile teams are at. There's about 16 mobile teams covering Pima County. And they, two different agencies run them, but because we have this common behavioral health authority, they give them the same GPS software on their phones and stuff so that they can track them. And so then they send the mobile teams out. These are clinician only. And then if the mobile teams do a face-to-face, then they resolve about 70% of those. And then for people who still need higher level of intervention, we have our crisis facilities, which I'll talk about hours in detail in a minute. And these are facilities that are open 24/7. They pretty much all have an overnight observation component to it. And people who go through those facilities, most of them, 60 to 70%, are able to be transitioned back into outpatient or community-based care the next day. And then after the crisis, for people who go through any of these services, you still need, the crisis isn't over, just slip off like a light switch after 23 hours. And so there are various post-crisis wraparounds, like peer-run agencies. We've got a transitions clinic that we've been running in Phoenix. We're going to bring it in the South soon. And then there's crisis residential for step down that aren't as intensive as, say, like the crisis center, but it's for people who need more structured time to continue to resolve their crisis. And then at every point along here, there's easy access for law enforcement. And there's this culture that's kind of baked into the way we do things, where if we're trying to keep people with mental illness and substance use needs out of the justice system, this is your intercept 0 and 1. It's the police who have those people. So we need to treat the police as a preferred customer, like we treat patients as preferred customers. So there's programs where they used to have some programs where 911 in the call center could like transfer calls, but they since went to just embedding the crisis line people into 911. And so that way they can sit side by side, they can intercept calls that don't need any law enforcement. And so they'll go completely down this clinical path and never touch the law enforcement system. And then they can switch calls back and forth if they need to. And then our mobile teams, like they have things baked into their contracts where, for example, if I'm at my house and I'm in crisis and I call the crisis line and they got to send a mobile team to me, their contract gives them an hour to get to me. But if I'm an officer in the field who needs help from a mobile team, they have half that. So there's things like that that kind of bake in this idea that you are treating law enforcement as a preferred customer. And then the crisis centers are all set up to be easier and faster to use than jail. So never turning officers away, really quick turnaround, like 5-10 minute turnaround. Now to the officer on the street, it's not all lined up on a PowerPoint slide like that. In reality, they've got all these different services. These are all the different agencies that are doing work in the Tucson area. And how are they supposed to figure out who goes where? And that's where this whole culture of collaboration comes through, and this culture of no wrong door, meaning that people should be able to access, you shouldn't put it on the officer to try to figure this out. First of all, officers are better than they get credit for knowing where to bring people. But if they do, quote, go to the wrong place, then the system works to get that person to where they need to be versus just going like, nope, you're at the wrong place. This kind of talks a little bit about the role of the state in this, because I was mentioning all this stuff around decreasing justice involvement. Like if you want to take like a purely, and I was saying it all like makes sense like financially, right? But if you want to take like a purely like financial person's view of that, why should the Medicaid department care if people are in jail? Because your Medicaid gets turned off when you're in jail, right? They're off your spreadsheet. But the further back you go, the money all comes from the same place, which is us taxpayers, right? So our governor did this smart government initiative a while back where he had the department heads share their budgets and create these cross-departmental goals. And so that's where there was a state level like strategic initiative to decrease justice involvement for people with serious mental illness. And then because of the way that Arizona does its contracting with its managed Medicaid, then that filters all the way down, because so if that's a state level goal, and so then when Access, our Medicaid department, releases the RFPs to be the Regional Behavioral Health Authority, it had questions in there that were like, how would you reduce justice involvement for your members that you're responsible for? They had to answer that, and all the answers were public. They had even like patient scenarios, and like, okay, well, what would you do to decrease, someone like this and their justice involvement? And so then when those REBAs if they win, then they have to contract out with all of us providers. And so that's where you see things like, I mentioned the mobile teams have incentives where they're supposed to respond faster to law enforcement. We have contract in language stuff in our contract language about our law enforcement turnaround time and things like that. So you can see how a statewide initiative can trickle all the way down to the individual providers with this structure. And so our REBA, our Regional Behavioral Health Authority, so they are not just an insurance company. They do all the stuff an insurance company does, but they do all these other things too. They're kind of like, I sort of call them our benevolent overlords, except for like when it's contract negotiation time, then maybe they're not so benevolent. But they do all this other stuff. They have dedicated staff. They have first responder liaisons that go out, especially in some of the more rural communities where, they may not get as much contact with the leaders there, where they're going out and outreaching and seeing like what's going on with your agency, or how are your officers interacting with the crisis system? Are you having any problems? they have tribal liaisons, because we have a whole bunch of tribal nations in Arizona. And so they have liaisons there that make sure that the services that they're getting out there are culturally appropriate. Like some of them actually will get on the phone when there's a call from one of the nations to make sure that nothing's getting missed and that the person, that they're communicating effectively. And then they do all these coordination functions. Like, for example, someone's in our crisis center, they need to be enrolled in services. We call the crisis line, and the crisis line dispatches somebody from the clinic that's going to be responsible for them. And they're supposed to come within an hour and start that enrollment process. So all these are things that like just your normal insurance company doesn't do. And it's because as the REBA and their contract requirements coming from the state and how they're accountable for the whole system, like is much more than just an insurance company. So at the heart of the system down in Tucson is the Crisis Response Center, which is the center that we operate. And this was built by a county with county bond funds. They built us a beautiful building. And it's important to note, though, that they built us this lovely building and they maintain it. And they lease it to the REBA for $1 a year, which is like the best rent ever. But they're not responsible for the services that occur in it. All of that comes through that structure I showed you before, through access, which is an important distinction because people want to know how you make these things sustainable. And like if a county government like puts up funds to build something like this, like how are they on the hook for making sure that this thing is seeing patients and doing its work forever? And no, and they shouldn't have to be either, because this is when I get a little soapboxy. Like we don't say, well, gee, where in the county budget and where in the police budget are we gonna find funds for, for all these heart attack patients? Like we don't do that. We expect the healthcare system to pay for that. So, it's sustainable that way, and that they build us a building, but the services come through the healthcare system. We have a larger facility in Phoenix that we lease the space and the county has nothing to do with it. So it's nice when the county builds you a great building, but it's not necessary. We see about 12,000 adults, 2,400 kids per year. In Phoenix, we see about 2,000 adults per year, but not kids. It's the main law enforcement receiving center. It has 3 different levels of care. So there's an urgent care walk-in where you can get your needs met within an hour or two. Med refills, being connected to services because you're new to town, that kind of thing. Then there's the 23-hour observation unit, which I'll talk about in a minute. And then for people who need to stay longer, for the adults, we have a subacute inpatient unit where people can stay like another few days. It's part of this cool campus. It's basically on the county hospital campus. The bond also built a 66-bed inpatient psych unit that's right next to us that the university runs, Banner and University Medical Center combined, and they run it. There's a breezeway that connects us to the emergency room. There's a mental health court right there. They do some criminal stuff in there too, but it's mostly like the civil commitment stuff. And the crisis call center's in our building as well. And how many people know about CIT, Crisis Intervention Training? Yeah, so CIT, people often talk about it as the training, the 40-hour training. And people who like teach CIT and are really into it love to remind you that the training is only part of it. It's really meant to be a whole community response. And because if you ask officers, divert people to treatment, their first question is going to be divert to what? Like if you go to the CIT conference, there will be sessions entitled the divert to what problem. And so these centers are kind of meant to be a solution to that. So if you pull up the manifesto, the CIT manifesto documents from like the 90s, it lays out what should be the ideal place to bring people for CIT to work. And the 2 in the middle we have highlighted because as we go around the country, those are the 2 the hardest ones that we see people struggle with, which is the minimal turnaround time and the no clinical barriers. No clinical barriers means that you take everybody. And by we mean everybody, even the agitated, violent, like intoxicated people that like nobody wants. Mental health has this reputation of being easier to access heaven than to get into a mental health facility. And it means being the opposite of that. We want the high acuity people. We think that they'll do better with us than in an emergency room. We don't use security because we have our staff that are highly trained, and we have the ability to de-escalate them, give them medications if needed. And, but it's better for them to be with us than in an ER on a gurney in a hallway restrained somewhere, or in jail. So we like those folks. They can't, some places like you can't be too intoxicated or too this or too that. And, we don't have any limits for how intoxicated someone can be. So, this treating officers as a customer. So what do they not like? They don't like to wait. They don't like to take their guns off. They don't like being turned away. They don't like having to parade somebody awkwardly through a waiting room with handcuffs on. So we've got, I think it's one of these things, it's critical to have their own entrance. We have this super fancy thing with a gated sally port where they push a button and it opens and closes behind them. We don't have that in Phoenix. The core thing, it's nice, but the core thing is that they have their own entrance, and you have a process to get them in and out as quickly as possible. So they have an office where they can do all their paperwork and their own bathroom and stuff, so they don't have to walk all over the facility. And then Tucson police are very progressive, and they changed their SOPs so that they don't have to handcuff. It's their discretion. If they do bring us somebody who's handcuffed, then we've worked with them so that it's our staff that has the handcuff key. And so then we unlock it to sort of send that message that you're here for treatment. And that in and of itself can be really de-escalating. The heart of the operation is our 23-hour observation unit. The criteria to get into here is pretty much the same criteria as to get into a hospital. Danger to self, danger to others, psychotic, agitated, intoxicated, in withdrawal. But our philosophy is that most of those people don't need to go to the hospital if we do very early and aggressive treatment. And so we start with this mindset, it's like a flipped mindset, that we are going to resolve the crisis. And so we immediately start working to do that. So we never put people on a list right at the beginning and say, you're going to inpatient, we'll start finding you a bed. We start working on resolving their crisis. So our door-to-doctor time's one of our really important metrics. We keep that around 90 minutes. We're staffed 24/7 with psychiatrists, nurse practitioners, physician assistants, as well as nurses, lots of peers, our behavioral health techs. Our social services staff is immediately on the phone, talking to families, talking to clinics, trying to find out what's going on. And then our peers are working in the milieu with people, working one-on-one, also doing groups. And then sometime within that 23 hours, we reassess them. And then if they've gotten better, we start, we continue working on their plan to get them out in the community. And if not, then we start looking for an inpatient bed. And so by having that mindset in that process, we get about 60 to 70% are able to go home the next day to some kind of community-based care. I put this slide up to remind me, because I forget sometimes. The substance use and mental health has been integrated for so long in Arizona, I forget to talk about it as a separate thing. But it is integrated at the payer level, so we don't have to worry about is someone coming in for a detox bed or a mental health crisis bed or what, because everyone who sees patients knows that most people have both, right? And we see a lot, only 15% come in saying, I'm here for a substance use issue, but 2/3 have some kind of substance use issue when you look at their diagnosis and their tox screens. And for all the attention on opiates, the vast majority of what's driving crisis is meth. And meth, then those are your most agitated folks, and the people that cycle through the most. I see nods over here. Yeah. So, and youth is mostly cannabis, and alcohol and opiates too. So the higher percentage of youth have cannabis as an issue. But we're able to do detox, we're able to start MAT, and so we can do that all in the crisis center, not have to worry about sending people different places to get stuff done. Now, after that 24 hours, we send people to specialty substance use care if that's what they need. But as far as when they come in, we don't have to try to sort out, well, are they psychotic because the meth or because they have schizophrenia? And it's like both, it doesn't matter. And so we'll get them the treatment they need. We don't do this in a vacuum. We are very fortunate to have a really progressive and really cool police department that we work with, Tucson Police. And they have bought into this. I was at National Council, someone said, that their police agency was like, they were struggling with them because they were saying, well, this is too risky for us to get involved in all this mental health stuff. It's interesting because the first time I saw our chief speak to other chiefs, he flat out said, this is a risk management program for us. Because the risk of not buying into all the mental health stuff was more risky in terms of officers getting hurt, bad outcomes happening, and lawsuits and all that kind of stuff. And so, very flipped mindset. So from leadership on down, there's commitment to better serving people with mental illness in the community. And it starts with like I mentioned, they changed their SOPs to not have to handcuff people. And so they've done a lot of stuff at the top policy level. And then all of their officers get mental health first aid training, which is the 8-hour training. And then CIT, the research shows that it works better if it's done on a voluntary basis versus voluntold. But you want a high percentage of your officers trained. So they've done all these things to incentivize it. Like you can't get certain promotions if you don't have it. And then plus also as people do it and they find that it helps them, you get like this word of mouth and stuff. So they've gotten like 60% of their officers trained. And then they have specialty teams that do nothing but mental health. And those teams are all CIT trained, plus further specialty training, like they get motivational interviewing and trauma-informed care and all this cool stuff. So what the specialty teams, this is an example of the first ones that they started. This was started in the aftermath of the shooting, 2011 shooting in Tucson, where Congresswoman Gabby Giffords was shot. And they were like, how did that guy fall through the cracks? And so they started these teams that just looks at people who have orders to be picked up, and they have detectives that then investigate the weird things. Like, cause there's, like my neighbor's acting weird. There's no like department for that in most police departments. And I was like, to me, it seemed like, oh, that's a good thing to do. For them, like it's such a culture shift to investigate things that aren't crimes. And I was like, I never thought about it that way. But it's like, well, yeah, you have like your robbery detectives, but you don't have a weird stuff detective. So they're the weird stuff detectives. This is kind of what because people talk about co-responders a lot, and this is what we've kind of evolved to. Like we didn't come out with this cool, like this pretty model and then say, this is what we're doing. This is just over the years, what we've evolved at is if you think about crisis, there's the acute response, and that's the orange part. And then after the crisis, there's the resolving crisis, or there's the pre-crisis, the stuff, there's opportunity for prevention. Because if you prevent people from, if you don't get people connected well after the crisis, it's going to be another crisis. And so all this blue stuff is kind of your outreach and prevention. So at the orange part, people talk about co-responders a lot. And we have a really robust crisis system already that's clinician only, because you want it to be that health first response, which is you involve clinicians and only involve law enforcement if there's a reason to have them there because of a safety issue or criminal issue or something like that. And so rather than sending co-responders out to figure that out in the field, we want to move that as far upstream as possible. So at the 911 call, figuring out who needs to go. And so if you've got urgency and risk on these two axes, if it's high urgency but low risk, then the mobile teams, the clinician-only mobile teams, should go handle that. And then they can take them to the CRC or do whatever. If there's a higher risk, say there's a knife, or there's some kind of safety concern, then you would send an officer. And then because we've got so many different ways to collaborate with the mental health system, like the sending an officer and the co-responder like together and having them always be together like Batman and Robin, like it didn't make sense in our situation because we're also a very huge by landmass county. And when we tried that, there was all this wasted time of just driving around like empty Pima County. And so the CIT, sometimes it's quicker. If you got a really good CIT trained officer, they can de-escalate that person and bring them to the CRC and drop them off, and it's like the fastest thing. Sometimes if it's, for example, a suicidal barricade, they will ask the mobile team to come and help them instead of doing SWAT team, because like they learned the SWAT team doesn't make any sense for that, because like if they're not going to come out for the 2 plainclothes guys, they're not going to come out for 30 guys in a tank, so they stopped doing that. And so it's really like, you've got all kinds of different types of collaborations that can happen. And so that's why we call it a collaborative response rather than saying like it is a co-responder model and it's always a co-responder. Now for the blue part, sort of same deal. This is like more, instead of just the acute response, this is multiple touches and follow-ups and sort of case managing kind of stuff and outreach. And so if it's low safety, then that's the responsibility of the mental health system. So that has nothing to do with law enforcement. If there is some kind of safety risk, like that high risk, looking for the needle in the haystack thing, like I mentioned before, around, looking for the next Jared Loughner kind of thing, then yeah, you have detectives do that, but we have them work with peers because they can help it engage and help navigate the mental health system. There's a specialty team around substance use that follows up. They have an angel program. So if they deflect and not arrest people for substance use, they follow up on them, and there's a grant for a peer from one of the community agencies to go with them there. There's a homeless outreach team that goes around in the parks a lot, does a lot of outreach, and they have a peer that goes with them who's from one of the housing agencies. And so there it makes, but they're not always in the car like working together. So that's why we kind of have shied away from just talking about co-responders, because that's like co-responders is like one type of collaboration, but there's many more in our system. This is just some data, because I know I only have a few minutes left. This is some data from those collaborative systems showing that they're deflecting people away from substance use. They're getting people into housing. This shows law enforcement drops at the crisis response center. And what's interesting, and then the circles are the turnaround time. And we try to keep that, like I said, 10 minutes or less. It's actually like more like 4 to 6 now, because this is like an older graph. But what's interesting is the light bars are the voluntary people they're dropping off. Most places we've been, and including up in Phoenix, when the police drop people off, they're under whatever your civil commitment emergency hold is. But one of our docs calls us the Uber police, because they go out and they engage with people and they say, hey, let me give you a ride to somewhere where you're going to get treatment. And they go with them voluntarily. So we have this 2/3 of our folks are voluntary coming from the police. And you've seen more transports happening over the years. I wasn't kidding about the SWAT team. They tracked that and they stopped calling SWAT team for the suicidal barricades. And that's another argument you can make at in your communities about doing this kind of thing, is because each one of those is like $15,000 to call SWAT team out, which I had no idea. The things that typically get our people picked up, taken into jail, those calls went down. Like I think community has their own. Like we were working with some folks in Ohio that have aggressive jaywalking as one thing they use to pick people up. And I was like, I'm gonna have to try that, aggressive jaywalking. This is from that substance deflection program. So this shows the arrests going down, and then what this is really striking is that, so like nearly 70% of the people that were offered on the spot, I'm not going to arrest you. And it's not you accept treatment or you get arrested. It's I'm not going to arrest you, and here's some treatment options. So most of them accept it, and the officers like it because it takes less time to do that than to cite them or do whatever. This is some data that was done up in Phoenix showing the impact in terms of costs and outcomes. So there's all the saved costs to the healthcare system, but also kind of more relevant to your folks is that you can calculate off time of FTE saved for the officers by not waiting around and waiting in ERs and doing all this kind of stuff, which, I know everyone's understaffed these days. And so that's a compelling argument. This shows where the money comes from. So in Arizona, everybody is entitled to the first 24 hours of crisis services. So if you fall from the sky and land on Arizona soil, you are entitled to crisis services. And this shows where all the money comes from. Our Medicaid director estimated a $370 million return on investment. And that doesn't count all of the law enforcement savings. If you look at where the money comes from, you see Medicaid and commercial or Medicare, commercial is zero. They don't pay for crisis services. Luckily, there is a bill in Congress to fix that. And I think y'all are going to get my slides. There's more info on that bill in there. But that will require all plans. Now, this is another good bipartisan issue because I think everybody agrees that because if someone with Blue Cross goes through our system, they get all the services, but the funding for it comes out of the state line item for indigent care. So I think everybody can agree that taxpayer funds ought not to pay for Blue Cross covered people when their CEO makes, I don't know how many millions. So I'm gonna, because I only have a few minutes, right? Well, I'll go through this quickly. So we like data. So we created outcome measures for crisis services just out of necessity. Where this is called a critical to quality tree, where we start to say, well, what's the outcome, the value that you want to bring, and then make measures that go with it. So we have a lot around how timely you get your care, least restrictive, like we talked about, discharging people to the community, but also converting people to voluntary. A lot of people come in involuntarily in the civil commitment system, and we want to try to engage with them and have them accept voluntary treatment. So even if they do end up going to the hospital, at least they're going on their own terms. We look at readmissions, people coming back. We have metrics around partnership. That's where our law enforcement turnaround time comes in and measuring that. And then that's making us some progress towards national standards. Our measures became the Arizona standards, which are in the SAMHSA guidelines. And then I'm working with the Medical Directors Institute at the National Council to work on more crisis system metrics. So there's a lot of work going on trying to get us to the point where there are some standards. People go, well, why aren't there all these national standards? Shouldn't there be? And crisis services are funded by Medicaid for the most part, which is the responsibility of the state. So every state is different. And so with some of these bills that are coming up in Congress now, we'll create national standards and create an Office of Crisis Services at HHS at the federal level to start to standardize this. Because if I say crisis stabilization unit here, it probably means something different than if I said it like one state over, because right now all the standards are just, they're so state specific. And just this last bit to kind of illustrate when you get everyone working together. So things with crisis is, I like this quote from Brene Brown, because she says, well, maybe stories are data with a soul. And every person coming into the crisis system, it is a story of someone not getting their needs met in the community. And it's like, each one you could do like a little root cause analysis and say, well, what failed? And so if you look at all that together, you can kind of you can find gaps in the community. If you've got a systems approach where people are working together on these things, you can kind of mobilize around that. So this is people who were being brought in by those specialty teams from Tucson Police, who under civil commitment, who were coming multiple times. And we were like, who are these people? And then it was because of some administrative thing in the way that they were all coming, like the paperwork wasn't done right on them. So really they came to us because they realized that they were technically kidnapping people, and we're very upset about that. And we were like, oh, it's a big deal. We'll call the clinic, we'll get the form. And because we're all like customer servicey, and they were like, no, we are kidnapping people. And I was very impressed at how upset officers get when they realize that they're kidnapping people. So good to know. And so we were like, well, who are these people, like, who keep coming back multiple times? And the police know, because they're the ones who bring them. And so they did some hot spotting, and all these orange spots are group homes. And so we had a project around, we called it the Group Home Guy Project. And the purpose of this isn't to go into this process and all the complexities of why this was happening. But the point is we got all these people in yellow or orange or whatever. All these folks were around the table, even though all of them aren't technically accountable to the REBA. They're all part of the community, but everyone has got this collaborative mindset. And we came up with this, if you're into quality improvement, this is called a swim lane diagram, where so it's a process flow, but every lane is the responsibility of a different agency. So we came up with this project where if someone starts to get agitated at the group home calls the crisis line. If they call 911 instead, the 911 kicks it to the crisis line. And this is before they were co-located. And then it goes through this whole pathway where the mobile team is involved and the clinic's involved. And then only if all those things fail do they bring them to the crisis center. And so you can see that those numbers of those went down as soon as we started that. So just to reiterate, the key ingredients are having this foundation of a systemic outlook, and having our services, we've got a great continuum, but aligning them towards these common goals, and really promoting this figure out how to say yes rather than look for reasons to say no kind of culture of it. And that it did take us, it didn't spring up like a mushroom either. So this is 20 years of evolution to get to here in Pima County. The later years has become exponential, but it started with just one city mental health court and CIT training. And then that, laid the foundation for all that came after. And then I have stuff, you'll get my slides. I have a bunch of stuff in here about, I like memes, but I have some stuff in here about some of the legislative things that are going on. Hopefully we'll get to when when you tell people that the police, you have to call the police for mental health, like I want them to have the same look my nephew gives me when I tell him that movies used to come in the mail from Netflix. He's like, what? It's like, you lie. But there's various bills going on. A lot of them are bipartisan. These are the two biggest right now that are floating around. This one is much more further along. This one has the equity for all the insurance companies to have to pay for stuff. This one's newer. This one doesn't have a, and this one, think about it. This is like Senator Bartow, Cortez Masto from Nevada, and John Cornyn from Texas, like agreed on something. It's like amazing. And so this one, they're still like working through the Senate to get it to the point where there'll be a co-sponsor. But both of these do a lot around workforce development, funding for crisis infrastructure. And at the state level, lots of states are passing telecom fees and things like that for their 988. There are planning grants from SAMHSA that are being given to the states to start to plan for 988. Well, not to start for 988, but a new round of them to plan for mobile teams, because that's kind of the next thing. The second bill up there has the infrastructure funds for the crisis centers, because then if you've got the mobile teams, they still have to take people somewhere. So you need the crisis centers. And then our roadmap roadmap to the ideal crisis system report. I encourage you all to pick it up and take a look. It's 200 something pages, so don't expect you to sit there and like read it from front to cover or whatever, but it has tools in there, like a report card to see how your system's going, and to look for things to focus on. We've started a learning communities. One of your counties is part of it with us, and we hope to expand that. The committee that wrote it, we just met right before National Council and are working on all these like supplemental stuff to go with the roadmap, plus our new website. So please take a look at that. And then there's just some links of ways you can kind of stay up to date, different bill trackers and things like that. And if you ever want to come visit us, Tucson's one of the law enforcement mental health learning community sites. And so the feds will sometimes fund a travel visit to come. So I would not come in July. But any other time, you're welcome to come.